you. So I would just ask you, apart from being a specialist medical educationist, I would say, because you, I think, understand what to teach and how to teach it, what gives you the special perspective on Corona itself? You've made some wonderful videos. I would like to know the background.
Yeah, as part of my, it's many different things. First of all, I love to teach, and I love to explain things. That's been something that's always been with me from the very beginning. Even in college, I was one of the people in the tutoring center that they would give us, as a stipend to teach the students. But in my particular case now, is because I'm a pulmonologist, of course, COVID-19 fits right into that category. And so, as opposed to many of the luminaries and professors and public figures who talk about coronavirus, there's very few of them that actually treat COVID-19 patients. And so it's a perspective to be able to be vertically sort of integrated in being able to keep up on the latest recommendations, science, but also when all that is done, going in and actually going what we would say in America, go where the rubber meets the road. So that's kind of where the tire hits the pavement, and where you actually go in and take care of patients and understand the intricacies and the difficulties. And so, just like in a military situation where the general worked up his way from the bottom and used to be a private in the military in boot camp and knows all of the things that has to be done at those levels, those of us who are teachers, but also people who treat patients, understand the intricacies and the nuance of dealing with patients, but also public policy.
Yes, definitely. So let me just start by asking this. So how do you see the corona epidemic right now? Do you think it's wrapping up? Do you think at its peak? Do you think it's on the rise? Where do you see it in, say, 5 years?
That's a good question. So the way I see it kind of going now is really based on the variants. And the way I like to explain it is, if you can imagine a 4-lane freeway where cars are going down in specific lanes of a freeway with lines, and there's a bunch of debris on the freeway. After a while, after about an hour or so, what you would notice is that the debris would only be at the edges of the lanes because the cars had blown the debris away. And that's how I see kind of the variance at this point. So independently across the globe, we're seeing the very same type of variants being formed independently. And I think it's because the variants of the virus is taking advantage of some weaknesses in the initial spike protein. And so they're finding that the same mutation is advantageous for it. Now, this is what they term as convergent evolution as opposed to divergent evolution. What they're saying here is that it seems as though there's very few ways or degrees of freedom for this virus to mutate. And it's finding the same thing over and over again. If it was not that way, if it was finding multiple different mutations that were making it advantageous, then I would say that maybe this is something that's going to hit us every single year, like the flu from now on, and we have to always be one step behind. But because we're seeing very similar molecular mutations in a specific advantage, both in the South African variant, both in the Brazilian variant, we're seeing the same similar change in the spike protein mutation. I believe instead of it being a mini series, it's going to be a final encore presentation. And once the Moderna and the Pfizer and other companies come up with that final booster to take care of that one last card that the virus has played, I'm hoping that will essentially, if we can get enough people vaccinated with that, end this pandemic. And so that's my hope, but we'll see what happens.
Let's see. Let's hope for the best. I will keep on asking questions until one of my participants raises their hands, and then I'll allow them to ask questions because all of us have a lot.
Sure.
In Pakistan, we are also having our third wave of corona. And in the first two waves, we seem to have done pretty well. Well, even WHO praised our government, the way it was handled. We managed to put a lockdown early on and partially opened it and controlled the deaths to a certain extent. But in this third wave, a new variant seems to have come up, and they said it's probably because of people who have been traveling back to Pakistan. And this time around, it's really deadly. We see, even in our own universities, we see people getting the corona, and within a week or 2 weeks, their lung from like being affected 40% goes to about 90%, and they're dying. Are you seeing such? Would you comment on that? And is a similar pattern seen in other parts of the world as well?
Yeah, so there's a lot of different variables that are determining how the country goes, and it's very wide. It's not, if you were to plot on a graph the percentage of the country that has been vaccinated and then plot on the y-axis how high the numbers are, you're not going to get a clear picture because every country is very different. For instance,
Mm.
you can look at the country of Israel, which had a lot of lockdowns early on, and they were having increasing rates, but they were very quick with their vaccination schedule, and now their numbers are going down. You could look at the United States. In some parts of the United States, like for instance in California where I am, the numbers continue to go down, fortunately. But in other parts of the United States, for instance in Michigan and New York, the numbers are going up. And it has to do with a number of variables in the equation. So whether people are sticking to the ideas of masks and distancing and things of that nature, whenever you see that being lifted, you're going to see an increase. I think it's too early to sort of just release. There are some people that are very responsible when things can open up and they continue to wear masks. Other people, when they hear that things are opening up, they just pull the masks off and say, hey, we're back to normal again, this thing is over with. And I think that's not a good sign. Probably the best example of that is the country of Chile in South America. There they have very high levels of vaccination, probably on par with around 25%. And
Mm.
yet their numbers are going up because they've opened up. The
Yeah.
other variable in the equation is variants. So these variants that have now come across, they have mutated in a way that allows them to bind more easily to the ACE receptor. And as a result of that, they are more infectious. There's higher counts in the nasopharynx. And because of all of those issues, there's even some evidence that says that they're more virulent and deadly. And so to the degree that people are not wearing masks and doing that and the vaccination, that's what's going to enter into that equation about whether or not counts are going to be going up or down.
Yeah. It's only been a couple of months since vaccination has started in our country, and only 60 years and older people were being offered, and frontline workers before. And now they have announced that 50 to 60 years old age bracket will be targeted. Um, there's one concern here that the vaccine which is coming in our country is from China.
Mm-hmm.
And one of the concerns amongst some of the scientists is that will the vaccine which is prepared against the variants China has be effective against COVID, which happens in Pakistan? So what are your thoughts on that?
Yeah, I am not so familiar with the data on Sinovac. Is that the vaccine you're referring to?
Yeah.
Yeah,
Yes.
I'm not familiar with the data on Sinovac against the
There isn't
variants.
much available.
Okay. Yeah,
Yeah.
that is going to be important to know that because it's
Mm.
not, I'm sure they're doing studies on that, and I'm sure you'll find out very quickly because that's an important vaccine, and one actually that had a pretty good um, uh, track record, we'd say, in China against the variant, against the initial wild type virus. But in terms of the variants, it's going to be important to know those numbers eventually. What I find to be the case in most of these situations, and actually there was a great paper that was just published in our country regarding the variants and the B cell and T cell responses. So again, you've got the immune response, the immune system. There is two ports to that immune system. There is the portion of the immune system that prevents the virus from getting into the cells. That's the innate immune system. Those are your macrophages. Those are your natural killer cells. That's interferon response.
Mm.
And then you have the adaptive immune system. the adaptive immune system, of course, makes the antibodies, the B cells and the T cells.
Mm,
When we're first infected with the virus, it's
mm,
potentially, predominantly, I should say, the innate immune system, which is trying to ramp down the number of cells that the virus infects.
mm,
Then at about 7 days after infection, you start to see the emergence of the T cells, the B cells, and the antibodies. And that's unfortunately, if you have many, many cells that are infected, you see this adaptive immune system response against all of those T cells. The
mm,
point of the story, though, is that when they looked at B cell antibody response against the variants, there was some escape. In other words, what I'm saying is that some of these variants, some of these mutations made it so that the B cells, the antibodies that are to eventually protect you the second time from
mm.
getting infected, there was some slip through. However, on the T cell side, the T cells, the mutations did not affect the T cell ability to do what they needed to do. What does all this mean?
Oh,
It means that, and what we're seeing, in fact, is that while the variants are having some escape from vaccination in terms of getting infected with the virus, so they may be infection, when it comes to hospitalization and death, which are usually the result of a T cell response that is inadequate. We're not seeing that. I'll give you a case in point. In South Africa, the South African variant, which is the most, other than Brazil, seemingly the most dangerous variant, when the Johnson & Johnson vaccine was tested in South Africa, there was about a 66% efficacy in terms of reduction of infection.
mm,
However, 49 days after the participants in the study got the Johnson & Johnson vaccine, there were no deaths in that group, not even hospitalizations in that group, telling me
okay.
that in terms of the worst outcomes, which is death, hospitalization, even these vaccines like the Johnson & Johnson are very effective at preventing death and hospitalization in these variants, even though they may be a little weaker on preventing infection.
Right. That is so interesting. So, Sana is a medical student. She just asked a question. Sana, would you like to ask it yourself? Okay. I don't know about her internet connected connection problem. She has said, I have a question. How important is it to follow all the SOPs even if we are vaccinated?
What are the SOBs again?
Wearing a mask, social
Okay.
distancing, using sanitizers, you know.
It's very effective. It's very important, primarily because of what we just talked about. So these variants, while the vaccines, at least the Johnson & Johnson vaccine that was tested, seems to be very effective at preventing the worst outcomes, which is hospitalization and death, they don't seem to be as effective at preventing transmission of asymptomatic infection.
All
I'll give
right.
you an example. The CDC just released, or the CDC in our country just released the results of a study primarily done in the state of Arizona, where they gave 4,000 healthcare workers, they tested them prospectively. About 3,000 of them received the vaccine either in 1 or 2 doses, and about 1,000 of them did not. And they looked at the efficacy of the vaccine. This was a Pfizer and Moderna mRNA vaccines. And they found that after one dose, just after one dose of the vaccine, there was about an 80% reduction in transmission of the virus, and a 90% reduction after 2 doses. That's just that vaccine. We don't know what it's like in Johnson & Johnson. In other words, it's not 100%.
Mm,
So the best way to prevent transmission of the virus, which is of course what we're trying to do,
mm,
as well as prevent hospitalization, the best way to prevent transmission is realizing that there are two ways that the virus can be transmitted. Number one, by large droplet. That's basically how the flu virus goes. We know all about that. When someone's talking to you, they can spit droplets and you can inhale the droplets or get it on your hand, rub your nose. Masks are 99.9% effective at reducing that type of transmission. The problem is, though, is that there's another mode of transmission of the virus, and that's airborne. And what I mean by that is, if you were in a small room with another person who's infected with the virus and both of you were wearing masks, if you were to remain in that room for a period of time, let's say an hour, there's a very good chance that you could contact the virus. And it has nothing to do with the fact that they're talking or anything like that. It has to do with the fact that when they breathe, the smaller viral particles become airborne and can circulate and fill up the air if there's no ventilation. So the way to prevent transmission is good ventilation. That's why people like to be outdoors. That's why if you're inside, you need to have good ventilation, crack the windows, make sure that there's good air movement so that the concentration of those viral particles go down. And also wearing a mask, especially if you're going to be within 6 feet, 3 feet of each other. So yes, still very important.
Yes, thank you. Sarah Vahit has a question. Sarah, please introduce yourself and ask your question.
Hi, Doctor. Thank you so much for giving us this time. Really, really appreciate it.
Yes.
I am one of the few unlucky ones who's not from the medical profession. So my question is going to be based on all the articles that I've been reading. Number one, I know we are on shifting sands and the data might not be there, especially in the US, but for relatives who are back home, there is this debate about getting the Chinese vaccination, Sinopharm or Sinovac, or Sputnik. That's the Russian. So love to hear your views on if you could be kind enough to tell if you think which one is the better one. And second, another quick question is relating to the talk that you were just giving right now about the airborne transmission of this disease. So I remember reading a couple of months back in one of the papers, it's not a medical journal, that it can be 6 feet is something that is being told because it's the more practical option. Otherwise, it can go up to 20 feet. And the example they said was that air was tested in hospitals and it carried it. So is it just conspiracy theories or would love to hear what your take on this is. Thank you so much.
Yes, absolutely. Thank you for the question. So I don't have as much information available to me, or maybe even many other people may not have it. I have to look into it to know which vaccine would be better, the Sinovac, the Chinese one, or the Russian one. My understanding in what I have read is that the Russian vaccine is greater than 90% effective. I don't have any reason to doubt that. But I would like to look at those studies and see if that is I'm not exactly aware of how effective the Chinese Sinovac one is, but I do remember reading and studying that the Russian one was fairly effective. And so that would be, whichever one seems to be more effective, that would be the one if you have a choice. I don't know if you have a choice, but at least in
yes,
this
we do.
country. Okay.
This is strange, but we do have a choice. So.
Good. Okay, great. In our country, you sign up, you go, and whatever they have, they have. So for the most part anyway, because we're trying to get it out so quickly. I need to do a little bit more research on Sinovac and the Russian Sputnik. I know they came out they were probably one of the first ones to come out. And apparently the efficacy based on their published data shows greater than 90% efficacy, which is great. Just need to look a little bit deeper on that and see in terms of testing. Now, in terms of how far the virus carries, there's no hard and fast rule. The 6 feet or the 2 meters is the integration of the science, the possibilities, but also the public health and the practicalities of this. So, if we could distance 20 feet, I'm sure we would try to do that to be 100%. But of course, it's not practical. So I would totally believe that there's probably incidences where the virus has gone out to 20 feet. Absolutely. That's certainly within the realm. Here's the thing, though. When it has to do with in science, we have something called in vitro and in vivo, and that's just Latin basically for in a test tube versus in real life. So you may be able to detect a viral particle 20 feet out, but the question really boils down to you don't really care if there's a viral particle that's 20 feet away. What you really care about is whether or not that viral particle can infect somebody. And there is something known as a viral threshold. So if you are inoculated with a very, very small amount of the virus, that's probably not enough for that virus to do what it needs to do. And so essentially that virus is there, but it's innate. It's not going to do anything. And this is actually a lot of the reasons why we believe early on in the pandemic that a lot of healthcare workers were coming down with the disease because they didn't know where it was, they didn't know how it was spreading, and they weren't wearing the protective equipment necessary to reduce the viral loads. This is also the reason why people might say that masks don't work, because they're not 100% effective, because the holes are bigger than the virus particles. Of course, they're not really meant to stop the virus, but it's the droplets that the viruses are in. And so a lot of the PPE, while it's not 100% effective at reducing virus, what it does is it significantly reduces the viral load. And so patients may, or people may still become mildly infected or maybe not even infected at all. But the clinical cases in those situations are going to be much more mild. So we have great data that shows that the proportion of the disease, the severity of the disease that is a result of the infection is directly proportional to the size of the inoculus or the amount of virus that the patient gets.
At
And
one
so
time.
probably,
It's not a cumulative thing, is it? I mean, at one particular time.
well, it depends. Yeah, it depends on how long the virus takes to infect. So throughout the course of a day, I could see how somebody who's getting exposed multiple times in small doses, if that accumulates, could lead to a bad outcome. But if it's a small dose here and then a day later a small dose there, that's probably going to be less consequential.
So the viral, I'm sorry.
No, Sarah, please continue.
I know this is so fascinating. Morbid, you can say, but when we talk about the viral load, is it true that the B11 is, if I'm saying it right, the Brazilian one, both the virulency and the viral load is much greater? And Pfizer and Moderna, what's your take that would we need to take another third booster for the Brazilian variant, or do you think they are covered? Because I got Moderna and some of the family members have Pfizer. So what's the efficacy? God knows what the new variant would be, but to the best of my knowledge, B11, the Brazilian one, is the most virulent one right now.
That's the one that we're concerned about the most. You're correct. I'm not aware of data. You may have noticed on our channel, we've had Dr. Shane Crotty, who's the immunologist out of La Jolla, San Diego, California, who's looking at just those very questions that you're asking. And in his latest video, he talks more about the South African variant, and we're less educated on the Brazilian one. Your question was whether or not we should get a third vaccine. That's a very good question. So far, in terms of preventing disease, hospitalization, death, it doesn't seem as though the Brazilian variant has escaped the Pfizer and Moderna vaccines. In terms of infection, in terms of spreading, asymptomatic transmission, and the ability to infect, there seems to be some leakage there. And so to the degree that you want to improve herd immunity and you want to shut that down and reduce the R0 value, which is how easily the virus spreads to other people, there may be a case to be made there for a third vaccine. They're already working on that, actually. They're already in the works of producing it and testing it to see. And as we mentioned earlier, you may not have heard, but as we mentioned earlier, I think that would be the final encore presentation of the COVID-19, because it seems as though all of the variants around the world seem to be doing the same sort of mutation and change on the spike protein, or very similar. So hopefully that would be that would be the last thing.
Thank you.
Yeah.
Thank you. Roger, I was thinking, is herd immunity going to be effective in long-term prevention of COVID-19? Could even without the vaccines, in those places where people are exposed to the virus, could they develop herd immunity on their own?
Yes, it's possible. It's just a matter of how well the herd immunity is. So what I mean by that is, and we're starting to get more information now about what happens when you get infected with coronavirus. Dr. Shane Crotty was mentioning that there's a 100-fold difference in the variation of antibody responses from a natural infection with coronavirus. So in other words, if I were to line up 1,000 people and have them all infected with COVID-19, SARS-CoV-2, and they get COVID-19, and then go through and actually test their immune response to that infection and line them up, and I were to take the person with the smallest immune response and the person with the largest immune response, there would be 100-fold difference between those responses, which is a very wide variation. The problem is, of course, is that if the person with the 100-fold difference were to be reinfected, he would have no problem. He probably wouldn't be reinfected because his immune response was so good. But those people at the lower end, of course, very well may be. And in fact, we've seen that where people have been infected and they've gotten reinfected. And of course, that doesn't tell us, that doesn't give us herd immunity, obviously, by definition. So the question is how far down that list do we go before we say this is the amount of immune response you have to get before you have herd immunity? Now, contrast that with the vaccine. People get the same dose, people are getting the same inoculation. And what we're noticing is that the immune response with the vaccine is actually more robust and more standard than it is with the natural infection. So that the assumption sometimes is that, wow, it must be that the immune response to the natural infection is the best kind of immunity you can have. And sometimes that's the case, but for instance, with the flu, in that case, the vaccine to the flu is not as good as actually just getting the flu in terms of immunity. But there are other diseases where that's clearly not the case, where it's better to get the vaccine than it is to get the natural infection. One of those examples would be the HPV vaccine for cervical cancer. People can get multiple infections with HPV and not be immune from other HPV infections, and actually could lead to cervical cancer. Whereas if you just get the HPV vaccine, that can prevent cervical cancer in 99.9% of cases after just one vaccination. So it's all over the map in terms of historical sense of, is it better to have the natural infection or is it better to have the vaccine in terms of immune response? It seems as though, based on the data that's coming out in terms of SARS-CoV-2 and COVID-19, you get a much more standard response and a much better immunity towards herd immunity if you get the vaccination. Now, that being said, what's the number that we need for herd immunity? And that goalpost has been moved many times in our country by, famously by Dr. Fauci. Initially, he said 60, 70%. Now they're saying 90%. Of course, when you start to say things like 90%, you've got to realize that 20% of the population are children and people less than 16 to 18 years of age. So then you've got to invoke vaccinating children, which is exactly what they're studying right now. And so the question is how much do we need to get herd immunity? And the answer is, well, we really don't know.
So if anybody has a question, please raise your hands. In the meantime, I'll ask if somebody has had the corona infection and they've recently recovered from it. Should they still go for the vaccine and when?
Good question. So your antibody response, it is felt in the first 90 days after a natural infection is such that they don't believe, or there could be a chance that a vaccination may not be effective. you want to stimulate the immune response in a way so that you make antibodies, and they feel that 90 days is that cutoff. So that what they're recommending, at least in our country, is that if you were to come down with symptoms of COVID-19, is to recover from that, wait 90 days, and then get the vaccination. And why would someone who's just been infected with COVID-19 need to get a vaccination? It's the same answer that we just gave here, in that there's a 1 to 100-fold difference in immune response to that. And to make sure that that person does have herd immunity, they're willing to use resources in somebody that may actually have immunity to get another vaccination, just to make sure. The other reason is purely clerical and practical, in that you don't want to waste time trying to figure out what someone's immune status is. It's just easier sometimes to just give them the vaccine.
Yes.